This is Kristen Hannebauer. I am presenting Detecting Sepsis for Early Diagnosis and Treatment for my Leadership in Management and Nursing from Murray State University. Today is November 22nd, 2015, and this is for Dr. Carol Murch. Problem statement. At St. Mary's Health implemented a protocol in 2014 called the Adult Severe Sepsis Screening Tool. This protocol was initiated in order to earlier diagnose and treat sepsis in patients admitted to the hospital. However, by early 2015, use of the protocol had decreased so much that it was almost not being used at all. On 6 East Oncology Hematology, the prevalence of sepsis is high due to the compromised immune systems of chemotherapy patients. After addressing these concerns with my clinical preceptor, who is a charge nurse on 6 East, we began our research into the problems. Objectives. 1. Sepsis protocol will be addressed on every patient coming to the hospital despite admission type. 2. Hospital staff will state the importance of the sepsis protocol. 3. Sepsis will be diagnosed and treated faster, leading to a lower mortality rate. The truth about sepsis is over 700,000 cases of sepsis present to the emergency department in the United States each year. Up to 28.6 of these cases end in death, and the total cost comes close to $17 billion. In 2012, the Surviving Sepsis campaign established guidelines that many hospitals have used to implement protocols. Studies have shown that these protocols have improved compliance with SSC guidelines and decreased hospital mortality rates. The protocol is a 3-tiered system that leads to a diagnosis. Tier 1 is the presence or suspicion of an infection. That can be pneumonia, a urinary tract infection, a skin or soft tissue infection, wound infection, bloodstream infection, or implantable device infection. Tier 2 is the presence of systemic inflammatory response syndrome, or SIRS, and that can include hyperthermia, hypothermia, acutely altered mental status, tachycardia, tachypnea, leukocytosis, leukopenia, and hyperglycemia in the absence of diabetes. If both of these are positive, then interventions should be made before addressing Tier 3. These interventions include notifying the physician and obtaining a stat order for lactic acid, blood cultures ×2, CBC with platelets, and a complete metabolic panel. With the results of these, Tier 3 should be addressed. Tier 3 is the presence of a multiple organ dysfunction syndrome, or MODS. MODS can include change in the systolic blood pressure, or the MAP, increased creatinine, increased bilirubin, a low platelet count, and increased lactic acid, or changes in the coagulation times. If this is positive, there's a 3-hour bundle and a 6-hour bundle for positive screening, which includes fluid resuscitation and antibiotic administration. Areas of improvement. Education has been the number one area in hospitals across the nation that needs improvement when it comes to using the sepsis protocol. I performed a general knowledge assessment on 23 of the nurses on 6 East, and less than 50% of the nurses understood the sepsis protocol well enough to utilize it for patient care, and 75% of the nurses felt there wasn't enough education provided to the nurses and physicians on the protocol. 85% also stated they also did not address the protocol on patients admitted to the unit or on patients that had a status change. On a chart review of 40 patients admitted to 6 East, 17 protocols were not performed, and 7 were performed incorrectly. Other areas of improvement. The second biggest downfall of this protocol has been with communications with physicians. Nurses note that physicians are either unaware of the protocol or do not want to be told how to practice medicine and therefore do not adhere to the protocol. Research. Some hospitals require nurses to take continuing education classes, modules, and RN champions to help educate nurses better to adhere to the protocol. Other hospitals made a physician communication script to best communicate the patient's symptoms, and noting earlier diagnosis and treatment will directly affect the patient's outcome. Implementation. With this information, I developed an educational flyer and in-services for nurses on 6 East. They were given information on the protocol and basic information on sepsis they could utilize when needed. They were also given information on best communication strategies with physicians. The nurse must remember it is not their job to diagnose sepsis, but to communicate changes in the patient's status to the physician so they can provide the proper diagnosis and course of treatment. I also worked with my clinical preceptor to address these concerns with the clinical nurse supervisors on 6 East and the emergency department, so they could also provide themselves as resources to other nurses when using this protocol. Nurses were encouraged to remember they do not need a physician's order to initiate the protocol. It should be addressed on every patient that is triaged in the ED and also on all patients who have a severe status change, as this can lead to a faster diagnosis and treatment. Sepsis facts. Sepsis can lead to poor perfusion, coagulation changes, and organ dysfunction that can lead to death and accounts for around 10% of ICU admissions. Since the initiation of the SSC guidelines, the nationwide rate of hospital readmissions due to sepsis has decreased with lower hospital costs. Using a sepsis protocol can decrease mortality and reduce length of hospital admission and rehabilitation. After the education was provided to the nurses on Sepsis, there was a drastic improvement of sepsis protocol adherence. Almost 100% of nurses, when surveyed, felt they were properly educated and felt they could adequately use the protocol. No statistics can be provided on decreased mortality at this point due to these changes being implemented less than 2 months prior to evaluation. The SSC guidelines provide a 5-year goal to decrease mortality. Setbacks in the future. There are many possible presenting signs and symptoms that can lead to a diagnosis of sepsis. Many times, these are overlooked due to comorbidities that could present with the same symptoms. This includes a patient with dementia that may present with increased falls, or a patient with a chronic indwelling catheter that may present with acutely altered mental status, as both of these can be symptoms of infection. In the future, it is hoped that protocol would be addressed on all patients that are triaged in the ED as part of the required assessment, as well as being part of the required charting on each shift for patients already admitted. In summary, in early 2015, the sepsis protocol at St. Mary's was not being followed by staff, and cases of sepsis were being diagnosed too late or not diagnosed at all. Through my clinical leadership project, I was able to increase education about sepsis to clinical staff and educate on the importance of the adult severe sepsis protocol. With SSC guideline adherence, it is hoped that mortality rate at St. Mary's Health will decrease and patient outcomes will improve. And these are my references. Thank you.